If you have multiple sclerosis, this is the single most important thing that you need to know about your diagnosis as an individual. This determines your treatment, it determines your prognosis, it determines your symptoms. So let's get into it and make sure that you know how to best take care of your MS. My name is Dr. Marwa Kaisey. I'm a neurologist and an MS specialist. And today we're going to talk about the different types of multiple sclerosis. Why is this important? Like I mentioned, it definitely determines the trajectory of somebody's MS, what symptoms they're going to have, what they might expect in a few years, and also very importantly, determines what treatments they're eligible for. There are disease-modifying therapies for MS that can slow down or even stop the disease, but picking the right one for the right individual really depends on several factors, including what else they have going on medically, but the most important factor that determines the choice of the disease-modifying therapy is what type of MS this person has. So given that this is so important, you might expect that we have a great test to tell what type of MS each person has. A blood test, an MRI. Unfortunately, we do not, at least not yet. The best way that I have for telling what type of MS somebody has, honestly, is to listen to them. I ask them their story, I ask them about their MS symptoms, how things have evolved over time, what they're dealing with on a day-to-day, and that is my best tool as a physician for determining what type of MS somebody has. So a little bit kind of in the dark ages, honestly, as far as not having a great test. MRIs can help somewhat. I'll explain how in a second, but really there's no one test that can tell us what type of MS somebody has. Just hopefully they have a good doctor who's going to listen to them and hear their story and determine it from that perspective. So what are the different subtypes? We'll start out with the most common, and the way that I kind of go through it in the clinic with my patients is to draw it out for them. I'm going to do the same thing for you here, and because I'm kind of old school about YouTube, I'm going to actually draw it out for you on a piece of scratch paper. I'm sure there are like nice add-ons where I could digitally draw it into the video, but we're just going to use a pen and paper today. So the most common type of MS, and 85% of people when they're first diagnosed with MS start off with this subtype, is relapsing MS, also used to be known as relapsing remitting MS. And so what this subtype looks like is that somebody is, let's say, kind of going about their life, and the way I'm going to draw this is, this is a smiley face, things are going well, sad face, MS symptoms, okay? And this is time, so as we move from here to here, time is progressing, usually on the order of months to years. So somebody's going about their life, let me use a different color to be clear. All right, bear with me. Somebody's going about their life, they have no symptoms, and all of a sudden, maybe overnight, they wake up and they can't see well out of their left eye. They have an optic neuritis, that's their first MS symptom, and that lasts for a few weeks, and then they go all the way back to normal. They don't have any symptoms left. That's what that would look like, right? We're doing really well over here, wake up, all of a sudden, not kind of gradual over time, but just overnight, boom, new MS symptom, gets better, they're back to their original baseline, as we call it. That's a relapse up here. This is a relapse. This is a remission. Things get better, right? Kind of like remission in cancer. It's where most people are familiar with that term. Things get better, they go back to normal. Now, if we don't treat, if we don't use any disease-modifying therapy, this will continue to happen. This person will most likely have another relapse, maybe worse, maybe like their left leg stops working for a few months, and they get treatment, they go to physical therapy, and that leg recovers, say 50%. This is what that would look like, right? So they're fine, you know, over maybe a day, the course of a day, that left leg stops working very well, they can't really walk. That lasts for a few weeks, months maybe. They're doing what they can to recover, and then they come back to here. So you'll notice this person didn't go back all the way back to normal. That would have been down here, right? The remissions aren't always 100%, and it's hard to predict who's going to remit 100%, who's going to remit 50%. Usually the remission of the symptom is somewhere between 1 and 100%, but where someone falls on that, we can't tell. So this is relapsing MS, RMS, or the older term is RRMS, relapsing remitting MS. Again, the remitting is kind of a little old school now because we don't know if somebody will remit, how much they're gonna remit, so we just call it relapsing MS, meaning big overnight changes, okay? This didn't come on over years, this left leg problem didn't even come on over months. It's really a course of usually hours to days that the left leg gets bad and it kind of stays bad and then it gets a little bit better. We do want to see some sort of remission to put it into this category usually, but like I said, not always going to remit. So that's the most common type of MS. That is the subtype where all the disease-modifying therapies on the market are approved for this subtype. So if you're going to have MS, this is the type to have because it's treatable, and all the treatments have been tested on this, and all the treatments have really been designed for this. Now, if this person continues on to have relapses, after about average 10 to 15 years, they may not have any relapses anymore. They may kind of continue on this where their last relapse left them for many years, like I said, 10 to 15 years. After that point in time, they may come into my office and say, you know, Dr. Kaisey, I haven't had a relapse in a long time. We've been following their MRIs. They haven't had a new lesion on their MRI in a long time. But over the last, they'll say over the last 3 years, I used to be a runner. And after this relapse, I went down to running maybe only max 3 miles, which to me is a lot, but to runners, it's probably not that much. I used to run 3 miles a couple of years ago, and then maybe 2 years ago, I had to go down to about 1 mile. That was my max. And then, about 6 months ago, I can't really run at all anymore. I'm just able to walk. And so what that is telling me is this person is having progression. There are no relapses, but they are progressing. Their symptoms are worsening. And now we're talking about a timeline not of hours to days, but of years, months to years, right? So what that line would look like is kind of a slow, more gradual worsening, right? So we're not having like a big uptick overnight, but over, they're saying years, their ability to run has gone away. And now they're just able to walk. So their ability to run kind of declined by miles every couple of years, and now they can't run at all. So that's what this looks like, this kind of general slope. This is the story for progressive MS. And if this person continues, they may continue on and eventually need a cane or need a walker to support their walking. And that's also an important question I ask my patients to understand the timeline of how things have gotten worse. Because a lot of times I ask them, when did your walking get worse? And they can't tell me exactly because it's been so subtle and so gradual. So then we got to get more specific. And I'll say, well, when did you start using your walker? And they'll say, about a year ago, I started using it every day. And then I'll say, well, when did you start using your cane? And they'll say, okay, the cane was about 5 years ago. So that gives me an idea of how long this time frame has been going on, this progression has been going on. Or if they're not using an assistive device, I'll say, give me an activity that you cannot do physically now that you could do 12 months ago. And sometimes they'll say, I used to walk the dogs, and now my husband has to walk the dogs because I'm physically not capable of making it around the block or of controlling them on the leash or things like that. So when I'm trying to get an idea of if there even is progression, I'll get granular like that. I'll ask specific questions about their lifestyle, what's going on, to help us kind of nail down whether there is progression and how quickly it's happening. So what is this subtype called? This is all about determining subtypes, right? This part is called secondary progressive MS, or SPMS. We already talked about why progressive, right? It's a slow progression of the disease symptoms. And the secondary is because it comes after this person had a course of relapsing remitting MS. Now, I told you that 85% of people with MS, when they're first diagnosed, are in the relapsing category. What about the other 15%? These are people who have a slow progression over time from the very beginning. And so that typically will look something like this, right? So they never had a relapse, but from day one, they start off okay. And then they suddenly, God, I realize I'm covering my face. They suddenly get worse and worse over time. They gradually get worse and worse over time. So there's no big sudden relapses, there's no big overnight changes, but there is a slow, gradual worsening, okay? That is called primary progressive MS. meaning we primarily started out in the very beginning with a progressive course. We skipped over this relapsing phase, okay? So now we have relapsing MS, primary progressive MS, secondary progressive MS. Those are the three big subtypes. Now, the other designation that becomes important for the progressive types of MS in determining if someone's eligible for disease-modifying therapy is whether they have active progressive MS or non-active progressive MS. So what does that mean? That means that some people are unlucky enough to have a combination of both types here. So they're having the progression, but on top of the progression, they may suddenly get overnight relapse. Looks like this. So they're having a slow gradual worsening over years, and then all of a sudden they get this big bump up, you know, a big inflammatory relapse, a new lesion on their MRI, something like that, that shows there's inflammation. So they have what I call both sides of the coin of MS. One side is inflammation, which is what drives new lesions, it drives overnight relapses, and they have the other side of the coin, which is the slow gradual progression, which is a bit more misunderstood or not as well understood at this point as to what drives it. It may be some form of inflammation that's more subtle that doesn't cause these big lesions on MRI. There's a lot of theories. There's clusters of cells that may be directly affecting the gray matter in MS, not the white matter that's driving progression. It may be brain atrophy. There's a lot of different things that can be contributing. But there's different pathophysiologic processes on both sides of the coin. This person has both. This is called active secondary progressive MS. So the activity refers to inflammation. You can still have progression, and it's called non-active. This is non-active. Very confusing terminology, because you can be progressing, you can be worsening, and still be classified as a non-active secondary progressive MS, which is actually more common, way more common, than active secondary progressive MS, which means that you have the progression and you have evidence of inflammation, which is a big relapse, new enhancing lesions on an MRI. Okay, so why is this important? It's because a lot of the drugs that are approved for secondary progressive MS are specifically only approved for people with active secondary progressive MS. You know, you gotta have this to qualify. And I just told you, most people with secondary progressive MS don't have this, luckily. They're not dealing with both sides of the coin at the same time. They're just dealing with this, it's still a big deal. But that means that these medications probably won't work for them because the meds are really designed to work on inflammation. That's why they work here. This is all driven by inflammation, right? That's why they work in people with active secondary progressive MS. But they're not going to work on the purely progressive form, which is again called non-active secondary progressive MS. Same with primary progressive MS. You can have active or non-active. Again, active is pretty rare. Interestingly, the one drug approved currently for primary progressive MS is Ocrevus, and in the trial for Ocrevus, about a quarter of people enrolled had recent evidence of inflammation, new MRI lesions or recent relapse, which is a really high number. I'll tell you, I have a lot of patients with primary progressive MS. It's pretty rare for us to find somebody with active primary progressive MS, meaning they have evidence of inflammation. I definitely don't think that a quarter of my patients with primary progressive MS have that. So the Ocrevus group that was used to study the drug in primary progressive MS was not exactly reflective of our typical primary progressive MS population. All right, so we got this down. We got the basics: relapsing MS, secondary progressive, primary progressive. There's other subtypes that come kind of pre-relapsing remitting. There's clinically isolated syndrome, or CIS, that precedes relapsing MS. So if you have kind of the precursors to this, you can have CIS. And the way things are going right now, we have a way of predicting who's going to develop MS after having CIS, and most of the drugs approved for relapsing MS are also approved for CIS. So this is like a precursor to MS. And then if you really want to get nerdy with it, there is RIS, or radiologically isolated syndrome. These are people who've never had a single MS symptom, which is required to diagnose MS. You have to have had a symptom. They get an MRI for another reason, like they have headaches or something, and we do an MRI. And the MRI looks for all the world like this person has MS, right? So what do we call that? That's radiologically isolated syndrome. So it's the MS MRI without any MS lesions. And there's a lot of research being done right now to understand who in this group should we be treating? Is this our first chance to intervene? Or if we treat all the people with RIS, are we over-treating people who may have lived their whole lives without ever having a symptom of MS and just happen to have these brain lesions that don't really cause any issues? So very interesting line of research that's very active right now, because as MRIs are becoming more and more available everywhere, we're doing them for different reasons, we're finding more of the people in this RIS group. So I hope this helped break down the subtypes of MS. Again, there's no test. It's really just based on, and I will literally like listen to a patient and then draw out their story like this, so they can see it visually, because I'm definitely a visual learner and I want to make sure that I'm hearing them correctly. And just based on that, we will determine what type of MS they have. Now, I said that people with relapsing MS go on to develop secondary progressive MS, and that it takes on average about 15 years, 10 to 15 years. Everybody's obviously very different. There's a way of not getting to here. There's a way of preventing this natural evolution of the disease and stopping things like right here, or even right here after the first relapse, and that is disease-modifying therapy. So if we don't treat people here, more than half, up to 80%, depending on the study you look at, will go on to develop secondary progressive MS. And again, at this point, we're trying to avoid that because there's not great treatments here, as I just told you. If we do treat in this part of the disease, that number goes down to about 10%. So there is a huge difference in risk of developing secondary progressive MS if you have relapsing MS, if you take disease-modifying therapy, and that disease-modifying therapy is accurately controlling or appropriately controlling your MS and not letting it progress like that.